On 26 April 1986, reactor number 4 at Chernobyl nuclear power plant exploded during a late night safety test. The blast released immense amount of radioactive material into the air, making one of the worst man-made disasters in the history. This nuclear accident released approximately 400 times more radioactive materials than the Hiroshima bomb. The subject of this case, Lyudmila, is the wife of the first responder, Vasily, a firefighter deployed hours of the explosion. Responders, including her husband, were not informed of the radiation risk and were not given any protective gear. At the systemic level, this reflects a critical failure in emergency communication, transparency, and occupational safety protocols. Exposure to extremely high doses of ionizing radiation caused rapid onset of acute radiation syndromes in the responders. Within 24 to 48 hours, symptoms typically begin with nausea, fever, vomiting, and progressing to severe internal damage. In this case, the husband was hospitalized into a specialized unit for radiation poisoning, where his condition deteriorated over the next 14 days, culminating in multi-organ failure and death. At that time, Lyudmila was pregnant with 7 months and was unaware of the biological hazards posed by close proximity to her husband. And she maintained physical closeness throughout his hospitalization, including skin-to-skin contact, without any protective barriers. These unprotected interactions led her to radiation exposure too, which later resulted in neonatal death of her child. So from a crisis intervention standpoint, this sequence of events involved multiple overlapping stressors such as an environmental disaster, institutional secrecy, spousal medical and psychological trauma, secondary physical harm to the spouse. The precipitating event, while the environmental factors kept in mind, became personally catastrophic due to the systemic negligence, lack of informed consent, and other ethical considerations kept in mind. Importantly, the crisis did not originate solely from the explosion, but from the deliberate withholding of critical information, transforming a tragic incident into a prolonged, preventable trauma for civilian families.
At first, Lyudmila didn't realize the severity of what had happened. The doctors kept telling the firemen that they'd been poisoned by gas. No one talked about radiation. Later, when Vasily was moved to a hospital specializing in radiology, the head radiologist told Lyudmila that his central nervous system and skull had been completely compromised. But she interpreted it as him being a little fidgety. When Vasily asked her to sit farther away, she brushed him off by calling it silly. She was in denial, her mind protecting her from the overwhelming reality in front of her. She didn't want to believe that Vasily could be dangerous to her or to their unborn child. But his condition worsened. Lyudmila felt like she was meeting a new person every day. His skin started peeling off and his body was breaking down. She said, "It happened so fast that there wasn't time to think or cry." Her mind couldn't keep up, so she went numb. 2 weeks after the incident, Vasily passed away, but his body was not given to his family. The state buried him in a sealed zinc coffin. The lack of transparency and the manner of treatment by the authorities ruptured Lyudmila's trust in them. 2 months after Vasily's death, her baby died 4 hours after being born. Lyudmila's initial understanding of the crisis was built on misinformation and false hope. After Vasily's death, institutional betrayal deepened the trauma that she was experiencing. Following the death of her child, her thoughts were dominated by guilt. She believed that staying close to Vasily directly led to their baby's death. Her distorted perception of the events led to intense survivor's guilt and self-blame.
So, the subject's psychological response can be understood through the lens of acute stress, prolonged trauma exposure, and post-traumatic caregiving. Initial reaction can be characterized by emotional numbing and dissociation, something which is typically seen in the aftermath of trauma where cognitive processing has been overwhelmed. She functioned on autopilot, suppressing her affective responses in order to remain physically present with her husband. This is a pattern consistent with dissociative coping in caregivers under extreme stress. The ongoing exposure to her husband's declining condition of burns, discoloration, and organ failure constituted a form of vicarious trauma. Unlike traditional caregiving, this involved not just witnessing but being embedded in the situation of irreversible decline without the ability to intervene or improve outcomes. Post traumatic caregiving is an emerging concept that describes caregivers who provide support during or after catastrophic events and subsequently display trauma symptoms themselves, especially when caregiving is paired with exposure to death and helplessness. Her recollections suggest traumatic encoding, sensory laden, emotionally charged memories that resist integration. These memories, coupled with the loss of a child, contributed to complicated grief marked by self blame and affective dysregulation. The co-occurrence of grief and trauma symptoms like intrusive recollection, hyperarousal, along with emotional withdrawal, suggests possible comorbidity of PTSD and persistent complex bereavement disorder. Despite the psychological isolation, the subject did find partial containment through shared narratives among other widows. This form of trauma bonding within a cohort of similarly bereaved individuals can function as a protective factor, providing external validation and a modicum of meaning reconstruction. From a clinical standpoint, her response underscores the interplay of ambiguous loss, moral injury, and post traumatic caregiving, each contributing to complex, enduring psychological burden that extends far beyond the acute phase of crisis.
As a mental health professional, addressing this case, intervention must be staged across both acute and long term phases, with particular attention to trauma, grief, and moral injury. Initial intervention begins with comprehensive risk assessment. The subject exhibits clear indicators of complicated grief, trauma, exposure, potential PTSD, and survivor's guilt. Assessing for suicidality, dissociation, and functional impairment is essential. At this stage, psychological first aid is recommended as an immediate non intrusive strategy. It focuses on establishing safety, stabilizing distress, and providing practical support, such as helping them access medical care, navigate social systems, and reduce environmental stresses. Psychoeducation should be provided to normalize their responses, explain the impact of trauma on the body and mind, and differentiate between adaptive grief and pathological processes. This can reduce self blame and foster insight into their emotional responses. Given their distorted guilt cognition, especially regarding a child's death, cognitive reframing strategies should be initiated early to prevent entrenched maladapted beliefs. Referral to restructured trauma informed therapy is critical. Evidence based modalities such as trauma focused cognitive behavioral therapy (TFCBT) or prolonged exposure therapy can help them process traumatic memories, reduce avoidance behaviors, and restructure guilt based cognitions. Grief counseling should address complicated grief symptoms, integrating techniques from models such as meaning, reconstruction therapy, and dual process theory to oscillate between loss oriented and restoration oriented coping. Peer support groups, especially among similarly bereaved individuals, can provide communal validation and reduce isolation. These groups often serve as informal corrective emotional experiences, helping the individual reestablish a sense of belonging. Finally, a critical therapeutic goal is agency restoration. Encouraging the client to engage in legacy creating activities, rituals of mourning, or advocacy, if desired, can transform passive suffering into purposeful meaning making, protective against long term demoralization. In summary, a multidimensional trauma informed and empowerment focused intervention plan is essential to support psychological recovery and adaptive functioning following such catastrophic loss. Thank you.